Well, welcome to Nurses at the Forefront, Essential Clinicians in Hospital at Home Programs, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine. We'd like to recognize the generous support of the John A. Hartford Foundation for the Users Group and for this webinar series. Just a few words about the Hospital at Home Users Group. It was formed in 2018 with the support of the John A. Hartford Foundation. It's a dynamic collaborative of hospital at home programs in North America working to promote acute care in the home. Right now, we have 93 full members who are serving patients, 358 affiliate members, which are developing programs or include other interested organizations and parties. The effort is led by 4 esteemed leaders in the hospital at home movement: Dr. Al Su from Mount Sinai, Dr. Bruce Leff from Johns Hopkins University, Linda DeCherry, formerly from Mount Sinai and now from Medically Home, and Dr. David Levine from Mass General Brigham. To learn more about the Hospital at Home Users Group, you can visit our website, which is noted there below, and to check out our TA Center for helpful resources and tools, and as well as a refreshed research center that is included there. And of course, please follow us on Twitter. This is the 19th Hospital at Home Users Group webinar. Throughout the year, the Users Group hosts webinars that explore pressing issues for hospital at home programs and important topics in the field. On our website, you can find the full list of our webinars, but also to access webinar slides and recordings. Just a note today, actually just I think it was 2 days ago, registration opened for this fall's Hospital at Home Palooza. It comes in 2 parts. First, the virtual Hospital at Home Users Group annual meeting on October 12th, 2023. That will then be followed by an in-person meeting at the American Academy of Home Care's annual meeting on October 13th and 14th, where you'll find a track of hospital at home sessions, 7 or 8 in all, plus a virtual networking group and some other hospital at home focused activities as well. We hope to see you virtually or in person. It's now my pleasure to introduce our moderator for today's webinar, Dr. Ab Brody. Dr. Brody is the Maddie Mezzi Professor of Geriatric Nursing and Professor of Medicine and Associate Director of the Hartford Institute for Geriatric Nursing at NYU. He's worked tirelessly to improve the quality of care for older adults through his clinical, research, and policy pursuits. Currently, he holds leadership positions at the NIA Impact Collaboratory and the NYU HHC Clinical Translational Science Institute, amongst others. Dr. Brody has been an active voice in the hospital at home movement for some time. He was a member of the evaluation team funded by the John A. Hartford Foundation for the Hospital at Home CMS demonstration project, where he focused on implementation evaluation, including the role, function, needs, and challenges of nurses working in the hospital at home setting. We're so pleased that Dr. Brody is here today to moderate this webinar. Dr. Brody, please take us away.
John, thanks so much. It is wonderful to be here with this fantastic panels and with all of you today. And I look forward to hearing a lot more about some of the current issues and challenges, as well as solutions in hospital at home nursing. And so I'm going to introduce our 2 panelists today. Dr. Catherine Baines, who's the Director of Patient Care Services for Virtual Care, which includes the Hospital at Home program at St. Luke's Health System in Kansas City. And Dr. Baines has been a nurse practitioner for nearly 20 years and held leadership positions in multiple healthcare systems and nurse practitioner organizations, as well as Candy Szymanski, who's the Interim Associate Vice President for the UMass Memorial Health Hospital at Home program in Central Massachusetts. And prior to joining this program, she held several hospital-based leadership programs was the Associate Chief Nursing Officer for Emergency and Psychiatric Services and the Chief Operating Officer for Marble Hospital. So thank you both for being here with us today. Thought before we got into it, if the 2 of you would mind sharing just for a minute a little bit about your programs and about how you got engaged to lead them. So maybe Candy first, and then Catherine.
Hi, good afternoon, everybody. I was introduced to this program post-retirement, so I did fail retirement, and I retired as the Associate Chief Nursing Officer for Emergency and Psychiatric Services in February of 2021, and then agreed to help support one of the COVID vaccine clinics. And as that was winding down, the Chief Nursing Officer called and said, there's an exciting new program. Would you be interested in, helping us get it underway? And first I had to Google what was hospital at home to learn more about the program, and then started to join the meetings. And, there were a few days where I just said, boy, I don't know if this is really possible, but I quickly learned that it is incredibly possible, and an amazing way to support nursing care for inpatients in their home.
And Kendi, about what's the size of your program right now?
So we opened in August of 2021, and we have admitted, I think it's like 1,230 patients to date. Our average daily census is anywhere from usually 14 to 16. The last couple of days, actually, we've been 17 and 18, which is great. We are budgeted actually for a census of 21. But, with many programs, I'm sure across the country, patient acquisition is, a challenge every single day. But we serve 23 cities and towns in central Massachusetts, all within about a 30-minute drive from our command center.
Great, thanks. And Kathy, would you like to share a little bit more about yourself and about your program as well?
Absolutely, and good afternoon to everyone, and thank you for having me join today. I became affiliated with the Hospital in Your Home program when I was approached by the medical director, who is a specialist in heart failure, and we had mutual colleagues from my work in heart failure. And given the fact that a large portion of patients that are cared for in this type of setting have heart failure, he asked that I join the team and oversee the nurses. And a lot of what's done is very similar to some work that I've done in the past with heart failure patients, specifically kind of joining the inpatient and outpatient side, although we were not using virtual technology at that time. And so it was just through networking and our overlapping collaborative colleagues that I had the opportunity to join the program last year when we went live in July of 2022. We currently serve the Missouri side of the Kansas City metro area, a number of counties. We have 3 entities that we have virtual units in at this point in time, and are planning to go live with our 4th entity in the St. Luke's system, which is on the Kansas side, and that should be going forward towards the end of the summer. To date, we've admitted about 455 patients, and our average daily census is around 10. So we're in the process of growing. And to Candy's point about acquisition, it is a challenge every day, but we have a good team. Both our physicians, our nurses, and our APPs actively engage in acquisition. And so there's a very strong team effort towards that.
Great, thanks. So why don't we kick off with our questions for today? First one that we thought would be great to ask is, no hospital at home program looks exactly like any other hospital at home program. So maybe Kathy, you can go first. What's a normal day look like for your hospital at home nurses?
Well, we do 7 to 7 shifts, 7A, 7P, 7P, 7A. And at shift change, of course, they get report. And then on the day shift, we have a multidisciplinary huddle that takes place at 8 o'clock in the morning. We found that to be extremely beneficial. We have our physicians, our APPs, our nurses, our pharmacists, our service coordinators, and our care progression team join on that call. And we discuss every patient, the plan for the day, what's happening with them currently during that call. So everybody's up to speed on what's going on and what patient needs might exist for the day. We talk about the schedule and when they're going to be seen and so on. So it's found to be a very helpful time. And then, of course, they they participate and engage all day long in interactions with the patients and making sure that they get all of the services that they need from our service providers in conjunction with our service coordinators. They're always participating whenever we have someone in the home, whether it be our paramedics or other nurses delivering wound care or whatever, our APPs, any type of other service provider such as PT or radiology. Of course, they participate in med administration and the verification of any narcotics that might be in the home. And they're always available to answer phone calls that come from patients. And they generally spend at least 2 hours a day just doing patient teaching. And we have a very strong nursing team with decades and decades of experience. So they have a great wealth of knowledge and are able to provide a lot of information to our patients about their disease processes, about managing safety issues in the home, and so on. They prep and complete all admissions and discharges, and they work through any logistics that might be challenging through the day, from communication issues to technology issues to things in the field with service providers. So they all have very full days when they work. Night shift a lot of times will be going through the records to see if there are any potential acquisitions during the day or during the night that we might be able to pursue during the day. And so that's been very helpful as well. We staff our command center currently with 3 nurses or 4 during the day, depending on the census, and 2 nurses at night. We do have a work from home option. And so most of our nurses are able to participate in that, but we always have a presence in the center on both the day shift and the night shift.
Candy, what's different about what you're doing in Massachusetts?
So our model is a little different in that first, we start also our day with a multidisciplinary conference at 7 a.m. And everyone who's working that day calls in or is here and logs in. And same procedure in terms of reviewing the patients that are currently on census. We run 2 separate teams. So 2 providers are on the phone running their list of patients. And again, just getting us prepared for the day. Our nurses do in-person visits. So usually some start actually at 6 a.m. Some, that sort of supports early phlebotomy as well as some 6 a.m. antibiotics. So they're already on the road by the time we do our 7 a.m. call. The rest of the team then is gathering all their equipment and supplies, printing off any, medication forms that they need for the patients in order to provide education and to schedule medications throughout the day. Grabbing IV fluids if we're going to give a bolus, and then, they're off and on the road. The nurses see 3 patients a day, which is really 6 patients. And then they're supported by 2 charge nurses, 1 for each team, and those nurses in charge really manage the logistics throughout the day. So they have some oversight for patient acquisition, for following any new orders, ensuring medications arrive from the pharmacy, setting up visits based on geographical location to make it as efficient as possible, answering any of the nursing questions. And then everybody gathers back again at 2 o'clock in the afternoon. We repeat a huddle just to update regarding any changes throughout the day, any planned discharges for the next day or later in the current day. Anybody who needs early labs the next morning, we review some new admissions. It is a very full day. From a staffing standpoint, we actually have staggered staffing. We don't operate a full 24/7. There is an overnight RN here Tuesday, Wednesday, Thursday, but we're supported by MIH paramedics the rest of the week so that we are able to support patients who need Q6-hour antibiotics or wellness checks overnight. And that overnight nurse will support going out and giving medications, answering any of the patient's questions. Our monitoring is done remotely through our partner Current Health. But again, as Catherine said, the team is incredibly busy, and with admissions, discharges, lots of time for patient education. So yeah, it's a very, very busy service.
great starting point for where we're at. So we're going to talk a little bit about nursing workforce now, and I'm going to talk about a couple of questions about how do we focus our work in hospital at home versus nurses versus everyone else. So John, if you could actually go back to Q2. So there, I'm going to ask a couple of questions that are on here, these slides, and maybe one additional one that's not, but can you share a little bit about what skills a hospital at home nurse needs to develop to be successful, since this is not how nurses are educated in colleges, including my own. It's not what they normally see in the field when they start their nursing career. So what does it take?
When we first started, we predominantly recruited and hired emergency department nurses. And that was specifically done because, they're generalists. So they're comfortable with patients with various diseases, but they're also expert. They have expert IV and phlebotomy skills. They can do EKGs almost on the fly. So when we first started, that was our core team, was a group of emergency department nurses who were also looking for a very different and unique way to take care of patients. But I will tell you that we did learn over time that nurses who are comfortable working independently, who have great assessment skills, also were wonderful members of our team. So we recruited some folks from acute care, from home care, from hospice care. Everybody brings a little different set of skills and talent to the program. And we try to maximize those because they can, share their experiences and teach each other. And, to be honest with you, IV starts and phlebotomy are a skill. They sometimes take some time to learn, but they can be learned. And we have recognized that nurses from various backgrounds really bring a wealth of information to this very unique program.
Kathy, how about you? What do you have to add on this front about the skills that are needed to be successful?
Oh, I agree with everything that has been said so far as it relates to the skill set and people coming from different backgrounds. And I would say that the skill set is in addition to having excellent assessment skills, excellent clinician skills, and being able to use the nursing process effectively with regards to assessment, diagnosis, planning the care, implementing the care, and evaluating the care that's been delivered. And so I think the communication skills, in addition to the ones that just develop in a patient care setting, they need to really have good communication skills. I think being very strong in critical thinking, because to some extent their ability to assess a patient in the way that they're used to is different, and so they have to really think beyond what they're actually seeing and think about all of the different possibilities that could be considered that they might not actually be able to determine, since they don't actually have their hands on the patient. I think they need to be very adept at multitasking and adapting to a changing environment, whether it be related to a service provider that is having some challenges in the home, to a patient having a change in their clinical condition. And they obviously need to be ready to identify and address all of the various needs that patients might have in this particular model of care. So, from my perspective, the nurses that engage in this type of healthcare model, whether it be hands-on and face-to-face like Candy's group, or it be virtual like our group, I think they have to be the cream of the crop when it comes to their nursing skills and other skills around dealing with patients.
Oh, and I couldn't agree more. I think this group we've also learned a lot about the social determinants of health. So we have made that a priority for the last year and even going forward to really bring that to the forefront in terms of, we do our clinical assessments, but there's a whole environmental, social determinants of health assessment that's incredibly important to this. And then, the whole technical skills, our patients are, of course, given a tablet, a 24/7 monitor, just learning how to set that up and make sure all the communication works. So it's, the skills are really very diverse. But Kathy's absolutely right. They have to be amazing communicators, very comfortable with their assessment skills. In our case, they're in person and they can do that in-person assessment, but they get a really good look at the environment and can put all those pieces together so that going forward, hopefully their primary care provider has a better understanding of who the patient really is in terms of, their living environment, what kind of support they have at home. All of those things, I think, are incredibly valuable to putting a holistic picture together of our patients.
So we covered a lot there, and it also brings back together that you guys have a little bit of a difference within your model, and we're going to keep on this route for the moment. So I heard emergency nurses, I heard home health nurses, I heard a whole bunch, and each of those groups brings their own strengths and limitations. So if we're thinking stereotypically, I'm not going to let you guys get in trouble, so I'll frame it. Stereotypically, our emergency nurses are there for that short, maybe 1 hour to 24-hour stay, right? So it's about a short-term relationship building versus acute care, and then sometimes beyond is a little bit different for an emergency nurse, and they don't practice in the home. Versus the home health nurse might not do infusions or some of those technical skills, or deal with acute emergencies in a certain way that is more apt for what hospital at home would do versus, say, a med-surg nurse. So can you tell us a little bit, and I'm just giving these as generalizations because every nurse is different in their background and experience, but how have you successfully recruited nurses for your hospital at home program, and what have you needed to really build their competency in this unique model of care? And we can start with Kathy for this round.
Sure. I would say that our success in recruitment, and I believe we have been tremendously successful because from my perspective, we have absolutely the best nurses in the entire system as far as their skill set is concerned. And I believe that our success has been primarily related to a strong network, both within the nursing community, internally and externally, and as well as with some of our physicians, particularly our medical director, Dr. Nassif. We also have a very strong talent acquisition team that is ready to direct qualified candidates our way, and that's been helpful as well. We're very careful to screen for interest, any kind of interest, and a certain level of comfort and proficiency with technology. I just hired a nurse not too long ago. When I asked her about how she felt about technology and was she comfortable with it, her response was, "I love technology." And so that was, obviously a very positive thing. I think probably the most important thing we've done to build competency in this model of care is to listen to their needs. Where are they challenged in delivering the kind of care that they know patients need, and finding out where those knowledge gaps are, and then providing them with either expert input from other partners that we have, if necessary, or developing some type of tip sheet that they can have readily available and refer back to until those particular processes and workflows are reinforced enough that they don't feel like they have to use the tip sheet quite so often. We have multiple ways of communicating this kind of information out, and multiple resources that I think have helped them to gain that level of competency. One of the other things that we do when we hire new nurses into the program, after they go through their onboarding process, both as it relates to whatever they have to orient to within the system itself, but also specifically as it relates to this model of care, we have a survey that we administer to new hires so that they can give us some feedback on how successful we've been in setting them up to succeed in delivering the kind of care that they need to in our program. And that has given us some valuable feedback so that we're able to go back and tweak our orientation process, find out where we're doing well and where we may need to increase emphasis and bring clear focus so people really do feel prepared for the job that they have to do.
And the additional.
It's very similar. When nurses come to interview, we look for that excitement about taking care of patients. The love for what they learned in nursing school around patient education. You just, it's that sense of excitement. And I will tell you that several of the nurses here have said, I was just about ready to give up on my nursing career when I saw this new program introduced to the system. And I really was excited to see that I could go back to doing the kind of nursing care that I've always wanted to give. And so that's, it's so exciting to hear new applicants share that information with us. They, very similar in terms of this group will not hesitate to let you know what kind of additional support they need from a patient care or educational standpoint. So for example, we reached out to our wound care colleagues for some additional wound care education. We've reached out to our respiratory colleagues to give us an update on treatments for respiratory diseases, basic teaching for patients newly diagnosed with COPD. It's pretty impressive how many patients really don't know a lot about their medical conditions. And so as we come across areas where they want some additional education, we'll set that up for them. For example, we've admitted a few patients with hyperemesis and they've asked for some general OBGYN education. I'm trying, we met with our diabetes specialist colleagues to just review diabetes teaching, insulin administration, some of the newer insulins that are out there. So as new things come forward or they find that they want some additional supportive education, we're more than happy. And I learned something from all of those educational sessions myself. In addition to that, we have initiated monthly M&Ms. And the nurses are very active in their participation. For example, this month, we're going to talk about fall prevention, and we've asked some experts to, help us review a patient case and how we may have approached falls better. We'll review the Morse scale, how important that is to a patient assessment. So, we listen very carefully, and as I said, they're very open about what they'd like to have in terms of additional education and patient care support.
So it sounds like both of you have had to be really thoughtful in terms of the education is not going to be the same as your kind of cookie cutter med surg unit that does a specific thing, and it's all around that thing. It's a much more wide base, from getting people being comfortable in the home to the autonomy that comes from not having all of these other people around you, which can be very different and shocking for nurses who haven't worked in a home-based setting before, all the way to more of the acute care and the intensive and the technology component. So it's a very broad set of competencies that you have to develop, and new cases bring up these new issues to discuss. And so it sounds like you both really had to think on your feet and find resources there.
And they do a lot of problem solving on their own. Something as simple as, how do I hang an IV bag in a home? And they'll talk amongst themselves. What's the best way to set up medications for the patient? They do a lot of that problem solving themselves, which is pretty impressive.
So it sounds like, not that this is different for any other unit per se, but the culture of that unit is really important, because you have to be able to have colleagues who are in this together on this newer type of model, really working with each other to help deal with creative solutions to problems that they had never encountered before. So our next question to pose to you today is there, as I think everyone here probably knows, huge trends towards nurses leaving the field. And this is due to a variety of factors related to both the pandemic, workforce challenges, generational issues. You guys have alluded to this with a little bit, Candy, in your own story of coming back from almost retirement. Can you guys, maybe Candy first this time, share how Hospital at Home provides another outlet for nurses that are seeking a new challenge or might otherwise fall out of the workforce?
I think we've been very fortunate. Word of mouth has certainly helped us in terms of, our initial group of nurses sharing with their colleagues how amazing this is to provide care to patients in their home. The fact that they get time, they get the, ample time to spend with their patient doing education, and, sharing with the patient how best to approach their disease, how certain medications work. So I think word of mouth has really helped us quite a bit. And, as I said, several of the nurses have told us that this really brought joy back to their nursing practice because they can, certainly see their patients improve. And as I, said, they get great opportunities to spend providing education to patients and their caregivers, which is just amazing.
Yeah, I would agree with that completely. I definitely feel like the model of care, both just in its uniqueness and opportunity, as well as people that have been at various stages of their career and are needing a change of scene. Many, obviously, everyone was worn out through the pandemic. I think it has really been a shot in the arm for all the nurses. As far as their career is concerned, because I think that they have found not only are they able to provide excellent nursing care, but at the same time, I think they feel like they have their direct and even a greater impact on the actual outcomes compared to other healthcare settings that they may have worked in. The majority of our nursing staff comes from either a med-surg or ICU background. And oftentimes they would see essentially the revolving door of patients coming in and out for various exacerbations of chronic conditions. And I think in this particular model, they feel like by virtue of the fact they can spend as much time with the patient is relaxed and comfortable in their home in a familiar setting, that a lot of the teaching that is done is potentially more effective because it's an environment that's more conducive to learning from the patient's perspective. So I think they feel like they have a direct and even a greater impact on the actual outcomes for patients in a positive way.
And to follow up on this, how has retention been within your programs? Have the nurses who come wanted to stay? Has there been people who have found this isn't the right fit for me? What's that process been like, and how have you ameliorated when there are work environment concerns?
We've not had a retention issue. Our nurses have, I think, a high degree of job satisfaction, and we've not had any turnover per se. And so at this point in time, I think it's a lot of that, I think, has to do with the fact that we, as a leadership team, the medical director, the operations director, and myself are very involved. And I think that the nursing staff sees that we want them to be elevated to the highest position they can be as it relates to being able to deliver care. And I think there's just a lot of satisfaction with that. I think work from home has been a huge satisfier. And it has enabled people to hop on and off if we happen to have admissions or discharges that come up rather suddenly. And they always seem to be available to help out. And so I think that's part of the reason that we've not had a retention issue.
Yeah, I would absolutely agree. I think it's so unique and rewarding that we have not had a huge turnover issue. There are a few people who, have decided they'd like to go back to the bricks and mortar to advance their careers as a nurse educator, or to step back into a union environment, because this is a non-union department at this time. So but really most of them, I've not heard that anybody's dissatisfied. It's usually personal or family issues but the turnover is really quite low.
Great. So moving on to the next question. So one of the challenges that we've seen is that, and we even saw this back in the demonstration project, around families that would love hospital at home, but they would also love respite, for instance. So they want that break from caring for their loved one. And so the brick and mortar with the 24/7 care, so for families who have the means to cover a home health aide, they are able to cover a home health aide in the hospital at home model and keep their loved one at home, which is probably better comfort and quality and safety for them, but at an expense, versus those that don't have those means. We're now potentially creating another inequitable situation in a healthcare system that's already rife with those issues. So can you talk a little bit about caregiver needs, how you're meeting caregiver needs so that hospital at home can ameliorate some of these issues that might other arise around equity and who has access to the model? Hey, Candy, if you want to go first on this one.
Certainly, this is such an important question. We do certainly have patients who decline us, or their family members decline us, and I think that's the exact reason is some respite. But for those where we go home, or we're able to bring the patients home, that's part of our evaluation, to look at those social determinants of health, to spend some time with the caregivers. We do have excellent case management support on our team. We also work very closely with Elder Services of Worcester, so we can tap a number of resources. And some of those resources include, some home health aides or a PCA, at least to introduce that concept to the family, and then put them in touch with agencies who are willing to work with them around the financial side of, getting that additional support in. But I think it's incredibly important to recognize that it can be challenging to care for somebody that you love in their home, and any way that we can support that through one, just educating them about what resources are out there, because there are a lot of resources that people just don't know that they're there and available. So we try to introduce them to that. We can get a social work consult who can also assess the home situation, make some suggestions going forward. Sometimes, PTOT with simple suggestions like, handrails in the bathroom, and here's an easier way to help, your loved one get dressed in the morning. Some of those skills that we as nurses probably don't know very well. There are certainly a group of talented professionals out there that can support that. But we do spend time with our caregivers and try to appreciate, some of their challenges as well, and do our best to support them while the patients are on our service. And then at discharge, helping them find resources to continue caring for their loved one at home.
Kathy, anything else to add there?
Yeah, no, I echo what Candy has said at that point in time. I know we've done many of the same kinds of things, and I think that educating people about the resources in the community, as well as getting care progression involvement, home health aides, I think is an important thing. I know our in-home clinicians often will help patients with their medication administration as far as opening packages and so on are concerned. And that kind of relieves that task from the caregiver. There've been a number of times that we've had patients that, have agreed to the hospital in your home program, And but upon arrival at home, they acknowledge the fact that as their condition declined prior to their hospitalization, they just weren't able to keep up with taking care of their home. And so we've actually had some house cleaning teams that have gone in to help patients kind of get everything back in order so that they're more comfortable. It's a cleaner and more comfortable environment for them. And, you know, we also try to track why there is a decline. Occasionally patients will say, you know, they prefer the brick and mortar, but we try to track that if there's a specific reason so that we can make sure that our introduction to the program when we're in the process of patient acquisition is directed to the very things that might be concerns for patients and might cause decline, whether it be technology or, you know, just an unfamiliarity with how the particular health model works, and so on. So those are, you know, those are some of the things we try to do to support the caregivers.
Great, thank you. So our next question, you guys have different models, so this is a perfect question, tailor-made for both of you. You know, what are your thoughts on the virtual versus the in-person model here? Kathy?
Well, you know, to be honest with you, I think the more touches patients can have, whether they be virtual or in person, the better. I think it's very helpful for patients to understand that when they have a healthcare need, that there's an entire team, a multidisciplinary team that is engaged in caring for them. And, you know, nurses are the forefront of that. While our providers might direct the care in terms of what needs to happen for the patient from a medication or treatment standpoint, you know, the nurses are the ones that really deliver that care. And I think a familiarity with nurses is always a positive thing because I think it helps patients to know who they can connect with within the healthcare team and who will help to communicate their needs to the larger team, whether it be a physical therapist or pharmacist or our providers, our APPs or physicians. And so I think regardless of whether it's in person or virtual, that at the end of the day, the patients are benefiting from outstanding nursing care and they're the recipients of that care.
Andy, anything to add there? I see you nodding your head. Or is
No,
that...
I absolutely agree. I absolutely agree. You know, I can only speak to an in-person model because that's how our program is set up. But I think Kathy's point to the fact that, you know, the more touches the patients have, the better, and the more opportunities we have to impact, you know, great outcomes are beneficial for not only our patients, but their caregivers, as well as our nursing team.
I will say from a patient experience standpoint in our Press-Ganey survey, one of the surprising things that we found is even though all of our nurses are seeing the patients virtually, patients find that to be a huge satisfier. They have reported on their survey literally 100% satisfaction with the nursing care as it relates to courtesy and respect. Do the nurses listen to what you have to say? Are they responsive to your needs? And so that's been kind of surprising because we're used to, you know, really that in-person communication and in-person encounter between patients and nurses. So it's been very refreshing to see that this model of care can be just as appreciated and just as much a positive experience for patients as the in-person.
Yeah, and we actually found in our initial interviews with patients and families around this in the demo project that there were so many touches in person sometimes that created you know, a sense where they felt they had to be hosting even though they were sick. And so sometimes that virtual touch allows for that slightly less amount of in-personness. And so there are some benefits to that, although I will say that it's sometimes hard to read a situation if you're not eyeballing in person as well. So there are the benefits and challenges of both sides. So I want to make sure to get to our last question and then some audience questions. So I know there are currently some questions in the nursing field amongst some, but not all nursing unions about the role of hospital at home. Is this going to create challenges for traditional hospital nursing, Or, does this really expand nursing practice in scope and augment the traditional hospital nursing approach? So I'd like to get your thoughts on that question. Maybe Candy first on this one, since Kathy went first on the last one.
Thank you so much. This is such a thoughtful question. I'm not sure that it expands nursing practice or scope. I think that, the practice is essentially the same. It's just, in a patient's home. I think what it does is allows the nurses to provide a much more holistic, well-planned outset of care for their patient. They're able to put the whole picture together and see exactly, what the living conditions are, what some of the challenges are at home. Are there food insecurities? Do they have trouble, getting transport to their medical appointments, and, probably aren't the, always the most compliant at taking their medications. We're able to see that side of how patients take care of themselves. So I think that's, certainly beneficial to the nursing team, and eye-opening, of course, to them as they go into people's homes. We have, for the last year or so, had nursing students here. Which I just love. Even though this is not a program for novice nurses, it's a wonderful way to introduce nursing practice, inpatient nursing practice in an alternative site, care site. And I think that has been incredibly important for nursing students to see that you can provide amazing holistic nursing care outside the bricks and mortar.
Yeah, I would agree with that 100%. I think one of the things I really appreciate about the hospital at home model, whether the nursing care is delivered in person, as in Candy's group, or virtually, the way we do it in our model, is, it really goes back to the very roots of nursing and public health in the 20th century, when, there was a visiting nurses association. And I agree 100%. There's nothing like seeing the patients in their own environment to get a good feel for what their challenges really are, whether it's their diet or their environment, their lighting or clutter around or whatever it is, all of which, any of these things can be contributors to increasing the risk for adverse outcomes in health, whether it be contributing to a worsening clinical condition from a chronic disease standpoint, or fall. And so I think that we have had the opportunity at this point in time to open up avenues of delivering better care, because now we are able to be in patients' homes in a way and for a period of time that we've not had access to previously. So I think the end result will be better and better outcomes for patients down the road.
Great. And just following up on this from one of our audience questions, have either of you faced challenges? I know, Candy, you said that the nurses are not in a unionized program right now. So have either of you faced challenges in terms of kind of how you've interfaced or not with unions around the program with your nurses?
We have actually, and this nursing team has elected to join a union. I think the biggest challenge is around some pay discrepancies, not so much on an hourly basis, but perhaps some of their differentials. I think that is probably the most concerning issue for them. Their unionized colleagues get some additional differentials for being in charge. And of course, these guys get evening and night shift differential. But I think most of the issues we face are really around pay discrepancies. I don't think it's working conditions per se, but many of them came from a union environment. And I think that they are quite comfortable working in that environment and have elected to rejoin a union.
And for either of you, is it about the model itself, or it's just about kind of the general kind of having that union representation? So Kathy, I see you, or Candy, I see you nodding your head, Kathy. Any challenges that you faced around kind of the model itself?
We actually have had no issues with regards to unions, and I would say that one of the strongest draws for nurses is the actual model of care. I think they find it fascinating and exciting and challenging, and all of the things that they've enjoyed about nursing in the past as it relates to being good critical thinkers and having to be creative in how they deliver care. I think they're finding the same kinds of rewards and challenges that they found in other settings. And so I think the interest is what really draws nurses to this particular department.
Great. So next question I'm going to ask, can you each provide one strategy that has been the most successful in terms, that's creative, that in terms of patient acquisition?
Boy, that is a tough one. There are a number of staff who work on patient acquisition every day. One strategy that we have employed that is appears to be successful is an in-person RN in the bricks and mortar who will not only review patients and for those who are appropriate to the program, but then we'll go visit them in person and explain the hospital at home program to the patient as well as their family members. That model or pilot project appears to be very successful. But I think just on a daily basis, it's just, being relentless in your pursuit to bring patients home to take great care of them.
I agree with that. It is challenging every day, but I think one of the most important messages that we can communicate out to the broader healthcare community is that this model of care is actually better for some patients, a certain select group of patients, than being in a brick and mortar, specifically elderly patients that potentially could be on the verge of losing functional status if they spend too much time immobile. And I think that's one of the most important things that we can do is communicate that this isn't just an alternative for many, many, many patients. Some we've not even thought of as it relates to use cases. This is really a better model of care for them because it enables them to maintain a level of function. They're not exposed to the same intensity of hospital-acquired infections and so on. So I think that's an important message. And I think that with our multidisciplinary team, all of whom engage in patient acquisition, from nurses to APPs to physicians, I think that's probably been one of the most important messages we could deliver that has enabled us to have some success with acquisition.
So I think we have time for one last question, very briefly in one or two sentences. Are you measuring the same outcomes that are measured in the acute care from a nursing sensitive specific position, or are there different outcomes that you're specific focused on with your nurses?
We're a virtual inpatient unit, so the metrics are exactly the same in terms of, skin issues, medication concerns, CLAPSIs. So all of those metrics that are done in the bricks and mortar are collected for hospital home. We certainly look at harm scores. As Kathy said, the beauty of this program, our patients are free to move around in their home, so they're less likely to experience some of the downsides of spending time in the bricks and mortar. So I would say it's very, very similar.
Great.
I agree with that. We have the same metrics. The message that we are trying to communicate out, though, is that this is a different model of care. And so while there are metrics that we need to be following that are the same as the brick and mortar, we're getting into new territory, and there may be new ways of measuring metrics, quality metrics specifically in this particular type of setting that, that we haven't considered yet.
And I'm going to take the moderator prerogative. Candy, you talked about collaborating with nursing schools and having some of the more senior students come and precept, which is great. And so it sounds like you developed that relationship with your local nursing school. Kathy, have you guys engaged with your local nursing school at all? Schools?
Not yet, but it is on the radar.
Okay. So another area to look into, not that either of you don't have enough work already, I'm guessing. So with that, we are rounding out the hour. I'm going to hand things back to John Bellinson, and thank you both, Candy and Kathy, for this wonderful conversation. And John, take it away.
Thank you, Ab, and thank you to Candy and Catherine as well for your for a really interesting, provocative discussion. We were able to kind of cover all the questions that we were thinking about, as well as many of the ones that the audience has provided. Before we close, just a couple of notes from the Hospital Home Users Group. The first is about 2 research projects we have underway. One on a program standards survey, which is an anonymous survey of hospital home programs nationwide that are actually, to the last question, are designed to refine the standards sort of developed by our work group and see how hospital home programs compare. And the users group is hoping that you'd identify one person in your program to serve as a respondent. It could be you for a brief 15-minute survey. And you can see the QR code there to the right of the program standards survey. And then we have a minimum data set survey where the users group is building a minimum data set of hospital to home programs, patient and safety data to help programs improve and engage how they compare to others. Again, we'd like to identify one person per site to submit a yearly extract of patient and safety data. So again, scan the QR code and get involved that way. We also have webinars. Again, want to remind folks of all the webinars that have covered many issues in depth about hospital at home, and you can find those on the events page at the Hospital at Home user group, including the slides and the recording, particularly from this webinar in a couple of days. And finally, a reminder that the 2023 annual meeting of the Hospital Home Users Group is coming up on October 12th. It's a digital pre-conference of the American Academy of Home Care Medicine's annual meeting, which takes place October 13th and 14th in Seattle. There's the link to register. It's on the homepage of the American Academy of Home Care Medicine's information. Some further links for the Hospital Home Users Group. And finally, a thank you to our sponsors, the John A. Hartford Foundation, the American Academy of Home Care Medicine. Again, thank you again to Ab and Candy and Catherine. We really appreciate your time and energy and insights today. And we look forward to seeing you all next time as our webinar series continues. Thanks all.